All right. Afternoon, everyone. Thanks for joining. I'll just, can I please have a share screen? Thanks. Thank you. All right. So thank you very much to the organizers for inviting me to speak today. And my topic is instant restenosis, whether the options atherectomy is better, DCB is better, or if we have to use both. Here are my disclosures. The thing to understand with, is there an echo?
We can hear you.
Is there an echo? I'm getting an
No,
echo.
it's okay. You can go ahead.
It's okay. Thank you. All right. So instant re comes to treating it. So the vessel response to stenting differs depending on the stent compared to balloon angioplasty, certainly, but also differs between stents depending on the length of stent, the design of the stent, whether it's open or closed cell, the composition of the stent. So the old stents were all stainless steel. These days, most stents are nickel titanium alloy, and also technical factors with relation to the implantation. And this is where really stenting from healthy artery to healthy artery comes into it. Compared to balloon angioplasty, elastic recoil and negative remodeling as an early response are both eliminated. But there is still significant trauma to the vessel wall because you implant a stent, the struts have outward radial force, the struts themselves are traumatic. So the moment you get endothelial damage, you're going to get early thrombus formation. The body's response to that is a thing called intimal hyperplasia. So you get vascular smooth muscle cells migrating from the media and they replace that traumatized intima through the inflammatory response. That ends up with neointimal formation within 2 weeks generally, and the entire process is generally finished by 6 weeks. And the neointimal lesion itself is quite different to the atherosclerotic lesion, both macroscopically as well as on a molecular level. The other thing to note is that in-stent restenosis affects 30 to 40% of patients within 2 years of stent implantation, particularly in the femoral popliteal segment. So it's a common problem. We do have strategies medically to try and address it, but even with that, it still affects a substantial number of people. This slide is basically just showing the like a schematic of what we discussed with regards to the basic pathology of it. So you've got all these smooth muscle cells sitting in the medial layer. There's trauma from the stent. In the interstices, you get the thrombus formation and a platelet plug. And then as a result, to sort of cover that over, you end up with cytokine release and this neointima formed. And the restenotic lesion occurs at that point in time. It generally occurs more commonly at the edges of the stents because you get more growth in from the normal non-stented artery as well. There are two separate classification systems for in-stent restenosis. They're pretty similar. But the Maharashtra classification system says focal is less than 10 mils, diffuse is more than 10 mils in length, proliferative is more than 10 mils and extends outside the stent as well, and occlusion. The problem with the Maharashtra classification is that it's it started life as a cardiology classification system, and obviously stents in the coronaries are much shorter and behave a bit differently compared to stents in the peripheries. So a Japanese group led by Tosaka had a new classification system which said focal was lesions less than 5 centimeters in length, positioned in the stent body, edge, or both. Diffuse is anything more than 50 mils in length, and 3 is a total occlusion. So where do drug technologies come into this? Well, drugs modulate that immune response and the proliferative response. to the trauma from stenting. So anti-proliferative agents, which all started life as chemotherapeutic or immunosuppression agents for autoimmune diseases, such as paclitaxel, sirolimus, and everolimus, have been developed and put onto balloons and in stents as well, to try and reduce the proliferative response from the time of stent implantation. The trade-off to all of this is that you get a higher risk of immediate thrombosis because the platelet aggregates and thrombus within the stent interstices that we talked about first, those are not covered early. So it is really important that patients who get stents put in are put on appropriate antiplatelet agents, and certainly at the time of implantation are receiving an adequate procedural dose of anticoagulation. But what do we do when we inherit these patients who already have in-stent restenosis? So, well, we've got a number of options. For stent preservation, surveillance is important, so we're picking up more and more and more of these. But the options are plain balloon angioplasty, drug-coated balloon angioplasty, atherectomy, restenting, or a combination of all of the above. I'll talk mostly about DCBs and atherectomy, and then a little bit about the complications of each and when I would use what. You see on the right here, you've got two different types of lesions. This is clearly a higher grade lesion involving stenosis throughout the stent and indeed the vessel outside the stent as well. Whereas this one further to the right is a focal in-stent restenotic lesion. So DCB angioplasty, drug-coated balloons. So basically just a really brief overview of what is a drug-coated balloon. So the balloon itself is just a normal angioplasty balloon, but it has an incipient and excipient coated onto it, which has allows drug to sit on the balloon, and then when the balloon is inflated and you get apposition to the vessel wall, that drug is transferred from the balloon into the vessel wall to prevent the intimal hyperplastic response from occurring again. I treat these patients with plain angioplasty first to restore the in-stent stenosis to its desired luminal diameter because they're not cheap. They're more expensive than plain angioplasty balloons, and if you put one of these balloons in and you don't get the desired luminal gain, then you've essentially wasted a fairly expensive product. So I use plain angioplasty first, then I treat with the drug-coated balloon, coated with the antiproliferative agent, to try and ensure there's no negative remodeling. DCB as a sole strategy tends to work better in the in-stent setting in a more focal lesion. If you've got diffuse in-stent restenosis, you might need more debulking strategies. And again, as I said, drug-coated balloon angioplasty is not particularly useful if you can't restore the luminal diameter as desired with other either balloon angioplasty or other adjuncts. So it's pretty important that you properly evaluate the lesion with duplex ultrasound. First, you might choose to get a CT angiogram, though stents are not imaged the best with CTA. There's a bit of artifact sometimes. And then you can use intravascular ultrasound interprocedurally if you need to or you like it. So moving on to atherectomy. What exactly is atherectomy? So it's percutaneous plaque debulking. It is not a percutaneous endarterectomy. And this is what I think some people just fail to understand. They think that atherectomy is just a percutaneous, endovascular endarterectomy. It does not take out all of the media and the entire plaque the same way that an endarterectomy does surgically. It purely gives you debulking, luminal gain, and changes the vessel compliance. There are multiple different types of atherectomy depending on which device you choose to use. So there's directional atherectomy, and the directional device that I have the most familiarity with is Medtronic's Hawk 1. There's rotational atherectomy, such as Jetstream from Boston. There's orbital atherectomy, which is Philips. There's laser atherectomy, which is more of a coronary thing. I've never used it. And then there are devices like the Rotarex, which is more of an atherothrombectomy sort of device. I've got a short little video here, which I hope it will play. Here it is. This is just a video from Boston on Jetstream. So you can see that it's not doing a full-on endarterectomy. It is literally just coring out a lesion for you. So you see you've got your rotational cap, rotational tip, high flow jet of saline and aspiration to try and get rid of the debris, and you create a lumen that's, you know, roughly that size. You might get it a little bit bigger if it's a softer lesion because that flow effect tends to increase things. So atherectomy in in-stent restenosis, why do we do it? Well, the neointimal hyperplastic lesions do recoil early with balloon angioplasty because the rubbery neointima, to anyone who's ever exposed it surgically, we all know that it's very different compared to calcified atheroma. Atherectomy debulks it and modifies its compliance a bit, and it's got better evidence in longer and more complex lesions. It does expose the vessel to more trauma than plain balloon angioplasty, so adjunctive treatment's quite often necessary. There are a few pitfalls as well. You do need filters with certain devices because you saw in the video that you're basically shredding through that plaque with a bore like a tunneling or a boring implement. Yes, there is suction through that, but you may still have debris embolize, you may still trash, so fairly low threshold to use a filter. You also should probably take some caution if you've got single vessel runoff. The vessel and device sizes you need to know about, so depending on what size vessel or stent you're trying to deal with, the device you might choose to use will be different. There is a risk of perforation with these things versus having inadequate luminal gain. So if you use a small device, so to just give an example, the Hawk 1 comes in S, M, LS, and LX sizes. So if you are doing this for a 7 mil superficial femoral artery and you've chosen to use the M device, it will be too small. You have to be careful not to overdo it. There is a risk of perforation or capture of stent struts. I don't know how many of you have seen the pictures from the early days of atherectomy of people with multiple effectively saccular aneurysms or pseudoaneurysms from the SFA from people overdoing this. You can get early thrombosis, so intraprocedural, particularly if you haven't heparinized adequately. And atherectomy is not a sole tool. You cannot just do an atherectomy and leave. Atherectomy and drug-coated balloon angioplasty go together because the vessel trauma that these devices cause is too much for you to just get away with a plain balloon and have good results. You'll have much more early thrombosis, early recoil, just because the trauma to the vessel is that much. You need to know the stent that has been implanted that you're trying to treat and the device itself. So atherectomy of certain stents is contraindicated. The Supera stent is a good one, if you guys know that. That's made by Abbott. If the Supera stent is basically one single wire or nitinol stent that's made, or nitinol wire that's made into a stent. So if you capture that and pull one, the entire stent will unravel versus the rest of your stents, which have got individual components linked together. So I thought I'll quickly go through some cases to show you good and bad things. So first is a 70-year-old man who had a previous right ilofemoral endarterectomy and patch. And sorry, that should be right SFA stenting for rest pain and tissue loss. He'd had a previous EVAR, and he had a second toe amp at the time of his revascularization. His wound had initially healed, but at the 6-month review, it had broken down again with stenosis seen on ultrasound within the stents, and his toe pressure had dropped. So we planned him for a repeat angiogram and revascularization. Here you can see that I was lucky, he was skinny. So with the EVAR in place, coming up and over was challenging. I just chose to go antegrade rather than coming from the arm. And there was just about enough room to puncture the patch and get down. So you see here he's got this focal lesion close to the top end of the stent and another reasonably focal lesion in the distal stent and pretty reasonable runoff. So he just got straight DCB angioplasty, I did treat this AT lesion because that was his best runoff vessel. And you see there, just with balloon angio, so plain balloon first, then DCB, we got a very good result and got him healed. That's sort of as straightforward as it gets. But if you just go with plain balloon angioplasty for this, the lesion will come back. The next case is a little bit more involved. Right SFA stent, full length for rest pain. She lived in the country about 7 hours away from Melbourne. So her follow-up was a little bit sporadic, and she presented with a return of her rest pain over the past 5 weeks. She had reasonable conduit for a bypass, but she was pretty obese and comorbid, so we opted for an endovascular revision. Here is her CT that you can see at the bottom of the screen. So you see there, you've got the SFA stent completely occluded, and it's been 5 weeks, so you'll have a mixture of 𝐬𝐮𝐫 as well as superimposed somewhat fresh thrombus sitting in there. So here's what we looked like. I came up and over in her. She was too fat to go downhill. And managed to get through the stent. The important thing here is that you do stay intraluminal or intra-stent, okay? You don't want the loop is good, you don't want your wire going outside. So what I did was I got through all of this reasonably easily. I ballooned it with just like a 3 mil balloon so that I could track a device through. And then I got the Rotarex device. So the Rotarex is an atherosthrombectomy device, and it basically mulches up the plaque at the tip just like the 𝐧𝐞𝐚𝐫, but it also has a bit of a thrombectomy component to it for that softer stuff. So this is what we looked like after 2 runs of Rotarex, which, you know, it's a pretty reasonable looking result. DCB'd the entire thing, and here you go, post DCB. So this lady had really good stent salvage, and this has all remained patent with no residual stenosis 18 months post-intervention now. This is what can happen if you are not careful. 59-year-old guy in an occluded left fempop, performed for short-distance claudication, previously occluded an SFA stent. These were done in an outside hospital, and apparently the surgeon there had attempted to recanalize the SFA stent before going ahead with a bypass and couldn't get through. The guy presented 2 months after the return of his symptoms, and the bypass was deemed unsalvageable. He didn't have suitable autogenous conduit for a redo bypass, so we tried to recanalize the native vessel and stents via an antegrade and retrograde approach. Here is his CT. You see there's a long stump of SFA there, and then you've got stent down, and you think, oh yeah, this should be pretty easy, right? How did this other surgeon not get through? We prepped for retrograde access just in case there was some funny business going on. So here we go, we've come antegrade, we've got our pictures, and you say, oh, this should be really easy, right? Should be no problem at all. So anyway, through we go. You can see there's a wire through the whole thing, and we think, right, this is fantastic. Now, on that particular day, I didn't have access to other atherectomy devices. This was before we got Jetstream on the shelf. I didn't want to call the Rotarex rep in that day, so I had the Hawk 1 on the shelf, and I said, okay, fine, the entire stent's down, let's debulk it and use it. So this is what the Hawk 1 looks like. The cutter on the Hawk 1 is actually well back, 6 or 7 centimeters back from the tip of the device, the nose cone. This picture as well is a bit naughty because this looks suspiciously like a Supera stent, so I suspect this is going to end badly for wherever I pulled this from, because I didn't take, they didn't save the images of the Hawk going in to my case. He didn't have a Supera stent, so that was not the problem. The problem was we put the atherectomy device in, it made a very unhappy sounding noise, and the next picture I got was this. And you see my wire has traversed the stent struts. It's gone outside And I suspect what had happened on looking at the original pictures. We've talked about stenting from healthy artery to healthy artery. This was not done. This stent starts and ends in a subintimal plane. So my wire has taken a beautiful true luminal path because I did get wire from below. I couldn't get any love from above. And so I had to do some fairly, I don't know, sphincter clenching maneuvers to try and get this open again. So I had the wire through, I put a balloon up here and was like, okay, the balloon's going. And then I basically pulled this back to straighten it somewhat and then said, you know what, we're not going to worry about that. We're just going to reline the whole thing with drug-eluting stents. So I put in some 𝐬𝐵 PTX, and you see my 𝐬𝐵 ends below the old stent, which is over here, and then it extends much higher as well. I put a 6x120 and a 6x200 up above, and we got a really good result with the whole thing. So yeah, in short, atherectomy is good if you need to debulk a long length of lesion and modify compliance. DCBs alone are good if you have focal lesions, but beware the lesion that doesn't respond well to plain balloon angioplasty. DCB is not going to fix it. You do need adjunct. So atherectomy is a great adjunct, but atherectomy itself it's not the main course. The drug balloon is probably the main course. The atherectomy is the entree. And beware of all of these complications. Don't overdo it. It's pretty easy to leave someone much worse than how you found them if you are too cavalier. Thank you. Any questions?